Endocrine physiology, thyroid hormones. All right, so for the thyroid hormone section, physiological portion, it's relatively difficult to understand. I'm going to condense it into the most important high-yield things that you need to understand. But before I do that, I want to run you through what's going on specifically within the thyroid follicles, okay? And then hopefully from there, we can break it down and see what's going on with T3 and T4. Okay, so first off, we have the thyroid hormones, so T3, T4. T4 is known as thyroxine. And these hormones contain iodine, okay, which is very important to understand. And to begin off, we have iodine that's taken into the blood when we eat, okay? It's called iodide when we first eat it. And then the iodide is transported into the follicle, the thyroid follicle, and it's oxidated to iodine. Okay, and once it's iodine, it can be placed and used as a thyroid hormone production, okay? And the way that it gets oxidized is through TPO, okay? This thyroid peroxidase is very, very important. TPO, also known as thyroid peroxidase, is one of the most important enzymes in the process of forming thyroid hormones. And it's going to be the site of action for multiple drugs in hyper and hypothyroidism. So be keen to TPO. Now, what does TPO do? Thyroid peroxidase. One, we already said, it does oxidizes iodide into iodine. Okay, so we eat iodide, and then we have to convert it to iodine in order for it to be used in the process of thyroid production. Okay, next, iodine is going to bind to tyrosine molecules. Okay, tyrosine molecules are located on this thing known as thyroglobulin. So we have thyroglobulin that carries a bunch of tyrosine molecules, and what happens is our iodine is going to bind those tyrosine molecules. So keep in mind that the amino acid involved in our thyroid hormone synthesis is tyrosine. Once iodine binds the tyrosine molecules, it can form either T3 or T4. Okay, and that's the extent that you need to understand. And that whole entire process of oxidation of iodide into iodine and then iodine binding, known as organification and coupling, okay, that all happens through the enzyme thyroid peroxidase, TPO. Okay, so that's how we kind of get the synthesis of T3 and T4. Now, what you need to understand is that T4 is produced in much higher quantities than T3, but it's weaker, less potent than T3. Okay, so T3 is much more potent than T4, but T4 is produced way more than T3. And what happens is that T4, while traveling in blood, it has to be bound. Okay, but once it reaches peripheral tissue, it can be converted into T3 by 5' deiodinase in order to have its downstream functions. All right? So overall, let's start from the beginning. We have iodide coming in from the blood. It gets oxidized by TPO, and it changes to iodine. Iodine is going to get coupled and organified by TPO with thyroglobulins, which hold tyrosine molecules. And that tyrosine bound to iodine forms T3 and T4. T4 is way more produced than T3. Much more production of T4 than T3. But in order to act, it must change itself to T3 in the peripheral tissue via 5' deiodinase. All right, so 5' deiodinase is the enzyme that works in the peripheral tissue to convert T4 into T3 so that we can have downstream effects of our thyroid hormone. And then thyroid peroxidase, TPO, is the main thing that acts within the thyroid follicles to help produce our thyroid hormones. Okay? So now that's the whole entire process. Now the question is, what's happening with our anterior pituitary and hypothalamus? Well, the hypothalamus is producing our TRH, thyroid releasing hormone. It goes to the anterior pituitary, and anterior pituitary releases TSH, thyroid stimulating hormone. TSH then goes down and tells the TPO to be activated in order to produce T3 and T4. Okay, now this whole entire process is very, very important because the question is, what do thyroid hormones do? The functionality has to be important if this process is important. Well, let's start off with this. They say that thyroid hormone is important for brain maturation and bone growth, okay? And that's very key. So the first thing off rip that you have to understand is that thyroid hormones are needed for CNS development and brain maturation, okay? And so what happens is, if a child, in childhood, we have hypothyroidism, so we have an overall decrease in thyroid hormones, a patient can present with brain maturation difficulties, right? They don't have fully matured brain cells. So they have umbilical herniation, protruding tongue, and they have an intellectual disability. Very important. This is known as cretinism, okay? So that intellectual disability is due to the fact that there's not enough thyroid hormone because you're hypothyroid in childhood, and thyroid hormones are necessary for brain maturation. And the other two things you'll see is umbilical herniation and protruding tongue. But we'll talk about cretinism a little bit later on within the pathology videos. Next, it's needed for bone growth. It also is needed for beta-adrenergic effects and increasing basal metabolic rate. So what does that mean? It helps increase the sodium potassium ATPase pump, and it leads to an overall increase in O2 consumption. So without thyroid hormones, we have a decrease in basal metabolic rate, and you have an overall decrease in O2 consumption, respiratory rate, and body temperature, okay? And you'll see the association within our pathologies later on. Blood sugar is going to be increased glycogenolysis and gluconeogenesis. We get breakdown of lipids. And then lastly, it stimulates surfactant synthesis in babies. Okay, but the most important one I'd say is the brain maturation as well as the basal metabolic rate. Okay, it regulates those two things. Okay, now, lastly, the regulation of our thyroid hormones. We already said that TRH leads to a positive effect on TSH, which leads to a positive effect on follicular cells to produce thyroid hormone. Okay, now, there can be negative feedback within the system, and the negative feedback is primarily driven by free T3 or free T4. And the reason I'm saying free is because when I said T3 and T4 have to travel bound within blood, it means that they can't travel freely within the blood, okay? The reason it can't travel freely within the blood is because they are active when they are free. So we don't want constantly active thyroid hormones traveling throughout our blood and causing all of these functionalities, okay? Making its effects all across the body. So we bind them, one, due to the fact that it can't really stay in plasma, okay? It can't travel in plasma unbound. But the ones that are free are gonna tell us how much thyroid hormone is gonna be traveling within the blood that are active, right? Because if you're free, you're active. If you're not free, if you're bound, you're inactive, okay? Inactive thyroid hormones. So our free T3 and T4 is gonna have a negative feedback loop on both the hypothalamus and on our thyroid hormone, or on our anterior pituitary. So free T3, T4 levels, if they're increased, it leads to a decrease in production of TRH in the hypothalamus and TSH in the anterior pituitary. So that negative feedback loop is important. Also, we have the thyroxine binding globulin, TBG, that carries the T3 and T4 in the blood, okay? And so if we have less TBG overall, we're gonna have less T4, T3 available to the tissues. And that leads to an overall increase in our free T3 and T4. And so we're going to talk about a couple situations where we mess up the binding globulin, the thyroid binding globulin, TBG, the thing that holds and binds our thyroid hormones and carries it throughout the blood. If we have any changes in TBG, we will see changes within the levels of T3 and T4. So let's start off with the first one. You're going to see an increase in thyroid binding globulins in pregnancy or when the patient is using birth control. So the reason behind this is because both pregnancy and birth control lead to an overall increase in estrogen within our body. An increase in estrogen within the body, and we'll talk about the estrogen's effects later on within the repro section, but estrogen leads to an overall increase in globulins in general. So if we have estrogen that leads to an overall increase in globulins in general, we're going to see an overall increase in thyroid binding globulins. And when we have an increase in thyroid binding globulins, we're going to see the body reacting. So let's think about it this way. I take estrogen, okay, so I'm pregnant or I'm taking OCPs, and I have an overall increase in my thyroid binding globulins, TBGs. So what happens to my free T3 and T4? Well, my free T3 and T4, they're going to be dropping because I have now T3 and T4 bound to my thyroid binding globulins because I have more available. So my overall free T3, T4 is going to drop. And who's going to sense that? My hypothalamus and my anterior pituitary, right? So there's no more negative feedback loop on my hypothalamus and pituitary from the free T3 and T4 levels. So what do? They release TRH, which releases TSH, and TSH is going to go tell the thyroid gland to produce more T3 and T4. So they produce more T3 and T4, and we increase the levels of free T3 and T4 back to normal. So this is going to be a key question to understanding. Like, there's probably about 10 questions that I got from just this concept. They will ask you, in pregnancy or with OCP usage or increased estrogen levels, what will happen to your total T3 and T4, and what happens to your free T3 and T4? The answer to this question is that you have normal free T3 and T4 levels, but you'll have an overall increase in T3 and T4 total levels. Okay, and I hope that makes sense. So let me walk you through that one more time so you can fully understand it. Estrogens lead to an increase in TBG, thyroid binding globulins. And when thyroid hormones are bound to thyroid binding globulins, they are inactive. So they cannot participate in any functionality or the negative feedback loop. They're just completely inactive. So estrogen leads to an overall increase in thyroid binding globulins, which means that more T3 and T4 will be bound. So we'll have an overall drop in our free T3 and T4. Our body senses that drop in T3 and T4, and we have increase in production of TRH, then an increase in production of TSH, then an overall increase in production of our thyroid hormones. The thyroid hormones are going to be produced up into the level that we get back to normal T3, T4 free levels, okay? But since you've overall produced more T3 and T4, your total amount of T3 and T4 will go up. Even though you've had a normal amount, you've now reached back to normal amount of free T3 and T4, all right? If that process doesn't make sense to you, just remember this. In pregnancy, OCP usage, or any time that you have increased estrogen levels within the body, your total T3 and T4 levels will be increased, and your free T3 and T4 levels will be normal. And that's secondary to the fact that those estrogen levels increase our thyroid binding globulins. And when thyroid hormone is bound to these TBGs, it is in its inactive form. I can't be clearer here. It's such a hard concept to understand. So many of my friends had difficulties with this. I had difficulties with this. So if you have any questions on this specific topic, please reach out. But it's very important to understand. Don't brush it off. There's probably about like 10 questions that ask about it. All right. So overall, we've covered all the thyroid hormones, source, the functionality, and the regulation. And the last thing that we need to cover is the drugs. So there's a couple drugs that we need to know. The first one is PTU. PTU is going to inhibit both thyroid peroxidase, TPO, as well as 5' deiodinase. Okay? It's very, very strong. It's going to inhibit both the thyroid peroxidase, which is located in the thyroid follicles, and it's also going to inhibit our 5' deiodinase, which is in the peripheral tissue. Okay? The adverse effects of this is hepatotoxicity, very severe liver issues, okay? Very toxic to the liver. So we never give this drug. We never give this drug ever, except for one time. We only give this drug, PTU, when a patient is in the first trimester of pregnancy. That's it. That's the only time that you will be giving PTU, okay? And this is obviously going to be for patients that have hyperthyroidism because you're trying to block the production of our thyroid hormones. Okay, so the only time you give PTU is in the first trimester of pregnancy because it cannot pass through the placenta. And the rest of the time you don't give it because it causes severe liver toxicity. So the question is, what do you use most of the time then? Well, what you use most of the time is methimazole. Methimazole only inhibits TPO. It does not inhibit 5' deiodinase. It only inhibits TPO, methimazole, all right? And it's not hepatotoxic. So that's why we can give it to all of our patients. However, we can't give it in the first trimester of pregnancy because it is a teratogen. The patient in utero will come out with aplasia cutis, which is the loss of a piece of skin on top of their head. Okay? So, once again, PTU is going to inhibit both TPO as well as 5' deiodinase. We never use it unless it's first trimester of pregnancy because of its adverse effect of liver toxicity. Methimazole, we use it all the time except for first trimester of pregnancy because it can cause aplasia cutis, and it's a teratogen, but it does not have those liver toxic effects. Both of these can cause agranulocytosis, which means that you have just an overall drop in the neutrophil count, so a decrease in white blood cell count, essentially. And so that patient can present with like oropharyngeal ulcers, like they can have like ulcers in their mouth, and they'll have like fevers and generalized like infectious symptoms. So keep that in the back of your mind. If a patient's taking PTU or methimazole and they have these random infectious symptoms, start thinking about agranulocytosis secondary to those drugs. Also, propranolol can be used. It weakly inhibits 5' deiodinase. And so this is going to be the best for quickest symptom relief in hyperthyroidism. So if a patient comes in with hyperthyroidism, remember one of the effects of thyroid is beta adrenergic effects. So thyroid hormones act on the beta at the beta receptor. So if we give them propranolol, which is a beta blocker, it will quickly relieve the symptoms of hyperthyroidism. But you still have to treat them either with methimazole or PTU, okay? And the last one is glucocorticoids, and we'll talk about the glucocorticoids effects later on, but essentially it's going to treat one of the symptoms, exophthalmos, seen later on. But we'll talk about it in the pathology videos.